welcome you to Toronto, to the Toronto Course for Congenital Structural Heart Disease.
Thank you.
Where are you practicing?
Practicing at Mayo Clinic in Rochester, Minnesota.
Fantastic. Your practice is generally the greatest variety of what you see is in what domain?
We actually see a variety of patients from pediatric to adults. So I'm certified in adult congenital heart disease. In the cath lab, we see about 60% pediatric patients and 40% adults, and a wide range of pathology and heart defects and prior surgical history.
And you're the president now of Pisces, is that right?
That's correct, yes.
And what is Pisces?
So Pisces is the Pediatric Interventional Cardiology Early Career Society. It's an organization of early career pediatric cardiologists who specialize in heart catheterization. It's been around since about 2011. And we have a group of about 140 people around the world who are involved in one way or another with our group. We collaborate on research projects, we get together at conferences, we have a very active email listserv to share cases and ask questions on.
So I think that Pisces is a phenomenal organization, and really that's why we partner with Pisces to offer the course to members of Pisces, because I think there's a lot of content for fellows and there's a lot of content for more senior staff people, and yet that early career time in your career is really when you could use some extra help, could use a push, could use some specifically directed mentoring and things like that.
Right.
So what are you talking about during the meeting?
I have two talks. One is about paravalvular leak. It's a workshop that'll be on the second day, and then the first day I'm going to be speaking about complications from and during transcatheter pulmonary valve implantation.
Why don't we talk about the pulmonary valve implantation?
Okay.
Because I think that pulmonary valve implantation can be the most difficult procedure in congenital interventional cardiology. What is your how has the percutaneous pulmonary valve intervention changed over the course of the last, it's been around since 2006, first melody valve in North America. I'll give you a hint where that was.
I know, Toronto. Congratulations.
How has that changed the practice of percutaneous pulmonary valve intervention over the course of the last 10 years?
It's changed in a few ways. I think in one way we've been more aggressive, putting them in situations that maybe were off-label initially, certainly with the initial trials, which are very controlled as far as who is allowed to participate in those trials. So we early on found ourselves putting them in native outflow tracts if they would accommodate it. That was something that was excluded from the trial. Bioprosthetic pulmonary valves are another situation where we have actually done a lot of them ourselves. Our surgeons prefer bioprosthetic valves, and so we see a lot of patients with those, and that makes an easy landing zone for percutaneous pulmonary valves in the future. But sort of the flip side of that, while we've expanded the use of the valves in a lot of situations, and we're being a little bit more aggressive in some situations, I think we have a better understanding of what the risks are in these with these valves. I think early on we recognized the risk of coronary compression, but there's still a little bit of a learning curve to make sure that we are properly screening patients and preventing that from happening. The risk of conduit disruption was something as well that was recognized early on. We now, at least in America, or in North America, the U.S., we have covered stents, which you've had longer than we have, and that's made the use of pulmonary valves a little bit more available. But then I think we're starting to recognize kind of the long-term risks. Endocarditis is one in particular that we've become aware of. Early on, we recognized the risk of stent fracture with the melody valve, and that changed entirely how we implant them. Now in conduits, I don't know anybody who wouldn't pre-stent a conduit before putting in a melody valve to prevent that from happening. And I think we're learning a little bit more about thrombus, the risk of thrombus. There have been a handful of reports of valve thrombosis within the first 2 to 6 months after valve implantation. We don't know yet what the risk factors are for that, but it does happen, and then knowing how to address it and how to screen for it and how aggressive to be with anticoagulation, either empirically or at the moment we recognize some change in the function of the pulmonary valve. So it really is, there's a lot going on still as we're trying to refine the right situation for putting these valves in.
So you brought up a number of, and I completely agree with everything you said. What are you doing at the Mayo Clinic? I have a number of questions I want to ask just about generally practice, what you do, what the flavor of the procedure is at Mayo Clinic. What are you doing post-procedure in terms of therapy, antiplatelet, anticoagulation? How long? What are your recommendations?
That's a great question. We don't have a protocol yet. We certainly are treating everybody at least with an antiplatelet agent. Where I get a little excited when somebody comes in on warfarin for atrial fibrillation or another reason, because I know I can continue that without a whole lot of pushback from the patient or the family. I think what we've seen on the surgical side of things, at least our surgeons will treat for 2 to 3 months after a surgical pulmonary valve replacement with a bioprosthetic valve. They'll treat with warfarin, and so I think that gives us a little bit more flexibility in being aggressive in that way. And I think as we look ahead, we'll probably find that we're going to do that more and more for 2 to 3 months after valve implantation.
So oral anticoagulation for 3 months. And what about after that very early period? Do you make any recommendation for long-term antiplatelet therapy?
I recommend antiplatelet for life, as long as they have a valve.
It's very similar to our recommendations as well, especially with the data from Paris and there being potentially some type of thrombotic mechanism to endocarditis. So we pretty much switched over to lifelong antiplatelet therapy. I wanted to know if there's anything particular that you do at Mayo Clinic that may be different from what's presented at meetings or the so-called standard approaches to pulmonary valves. Any different assessment or any different procedural tweaks that you guys have instituted?
I don't know that I would say there's anything unique that we do relative to other places. We've actually followed in the footsteps of a lot of institutions that have sort of preceded us with implanting in native outflow tracts. This is not in the pulmonary position, but we have a large population of patients with tricuspid valve disease, and so we have a large experience with tricuspid valve and valve implantation of the Melody valve and now the Sapien valve as well. Now, to be honest, I don't know that if you were to come to Mayo Clinic, you'd see things done a whole lot differently than are done in a lot of places in that regard.
What do you? What's your usage of the Edwards Sapien valve or the Sapien 3 valve or the XT valve? I'm not sure what you're using, but what's your usage? How often do you use that versus Melody? I'm just interested to know, kind of get a feel for what your utilization's like.
Yeah, our usage currently, it still favors Melody, but probably about 70% Melody, 30% Sapien. The Sapien, and we typically use the S3, I think primarily for the delivery system that comes with it, the commander system, which is a little bit easy to manipulate into the pulmonary position. Deciding between one or the other, it can be a bit complex. It usually has to do with the size of the area that we're placing the valve, that we feel like we can put in a larger valve with the Sapien. You can go up to 29 millimeters outer diameter, a little bit more than that, and so putting it in a large bioprosthetic valve or in a large dilated native outflow tract potentially. Whereas if we're limited and we feel like we have about 20 to 22 millimeters to work with, then a Melody valve seems to make sense. I think that's a primary distinguishing or determining factor for which valve we use.
You know, Melody valve, the endocarditis issue is an issue. Any special measures that you guys are using or special instructions you're giving to your patients about that?
We're giving the standard instructions if they have that fever that's unexplained for longer than a couple of days, that they should come in and be evaluated. We also worry a little bit about indolent or subacute endocarditis, so if we see a valve gradient that's increasing or new PR early on that we wouldn't expect or shouldn't expect to happen, we investigate that with blood cultures and being pretty thorough about that, recognizing the risk of thrombosis potentially or stent fracture also potentially causing valve dysfunction.
How often do you see the patients post?
I usually see my patients about a month afterwards, 3 months and 6 months after the procedure, and then potentially annual follow-up if it's unremarkable at that point.
Tell me, the experience with the large patchless outflow tract, how aggressive or unaggressive have you been? Have you been concerned about, pushing the envelope and the risk of embolization? I can tell you that for our own experience, that I'm far more concerned about sending somebody to the operating room acutely when, generally speaking, an operation is relatively low risk to replace a pulmonary valve. So I've been a bit gun shy when it comes to size and stability. I'm just interested to know what your guys' approach has been with that.
I would say we have a very similar approach. I think when you have very capable surgeons, as we do and as you do, and you're talking about a transannular patch, it's probably only going to be a second sternotomy, so not a very complex operation, a very safe operation. We have not been very aggressive in those situations unless a patient has an explicit interest in pursuing transcatheter therapy first.
I'm interested to know, when it comes to adult patients, the opposite end of the spectrum. So, for example, you have a small Hancock conduit, and the Hancock's notorious for having very small inner lumens. When do you try it? Do you have a cutoff for how small an effective orifice that you'll accept in an adult? And then, of course, there's like a bit of a sliding scale with the 200-pound man and the 85-pound woman. And what are your...
That's an excellent question. There are people who have tried fracturing valves, and the Hancock may fall under that. We have not done that historically. I think we look at a number of different things. What's the mechanism dysfunction of the valve? If it's PR without much of a gradient, then we would feel that we could put in a valve inside of that and still not have much of a gradient. But if they're presenting with a moderate to severe degree of stenosis and the leaflets look thin, and you wonder, is this related to dysfunction of the valve or some degree of patient prosthesis mismatch, then we would be hesitant to do that. We don't really have a cutoff for the size of the conduit. I think once you start getting under a 20 millimeter Hancock conduit, I would be hesitant to put a whole lot inside of that, because the Hancock is a ringed valve, and so you're going to be limited on the amount of space you have.
In your institution, are you typically, your approach, I'm just interested, is percutaneous valve for people who are unfavorable for surgery, or is it anyone who's eligible for a percutaneous valve gets a percutaneous valve as their primary intention?
We have shifted a little bit. It used to be that only those that were not great surgical candidates would come to us, or as an effort to postpone a third or fourth or fifth repeat sternotomy. We've been seeing more and more who come to us as their second operation after a transannular patch or after a conduit. And that's been driven, but we let that primarily be dictated by the patient and the family. We try not to push that therapy, because we do recognize that surgery is a very safe and a good option for those sort of things. We enjoy doing those procedures, but we don't want our enthusiasm for the technical aspect of it to kind of overwhelm the rational decision-making process.
And do all of your pulmonary valves go through a multidisciplinary conference before you offer them, or is there like a discussion with surgery for all the cases, or is that not the rule?
Not all of them, no. That'll be they all come in internally, so they're all seen by a Mayo Clinic cardiologist first, and often, I would say probably about 80% of the time, they do see surgery and cardiology either together or independently, and we communicate very closely. But on occasion, the referring provider will feel that they should go the transcatheter route, and they come to us directly. I personally always talk about surgery as an option, but I also recognize that usually they're coming to me with the intention to pursue transcatheter therapy.
I kind of share your thoughts. I like the idea of, I don't think that this actually happens, but I think there can be the outward perception that people are kind of fast-tracked intervention, and I think that perception, I don't like that perception. I like the idea that you're coming to a team and we're going to work together and we're going to try and make you an offer that's consistent with your values, your wishes, and so I kind of agree with you, Ashley. I think that's important. You know, there's a meeting for young interventionalists early in their careers. If you had to tell them the three most important things, the three most important pearls to know about or be aware about or to think about when you're doing a pulmonary valve, what would you offer up?
That's a great question. My first one would be I don't want to be too general, but I would say focus on the safety of the patient. Okay, especially as a young or early career interventionalist, you don't want to have a mortality in your first 3 years in practice, or however long you can, ideally. I've noticed a tendency in myself and in others that we tend to train in places that are doing a lot of exciting things and at times are very aggressive, and we feel the natural extension of that is to be aggressive as soon as we're on our own. And that might be fine if we have good mentorship, senior mentorship there at our institution, but that could also get us into a lot of trouble. So I would first focus on doing procedures safely, and with pulmonary valves specifically, I think that means make sure you know where the coronary arteries are, because I think that can be a devastating complication, more so than a valve embolization or a conduit tear. And I think that sometimes we, in our minds, we're focusing on the end point, which is I want to put this valve in, and we do an angiogram, and we kind of see the coronary, and maybe the balloon inflation is not where it should be, and that can get us into trouble. That would be my first recommendation. My second would be that when you are doing transcatheter pulmonary valves, even now, we always have 2 sets of experienced hands there, whether it's a senior fellow who has done a lot of cath and a consultant who has as well, or 2, but more often than not 2 consultants. Yep. And as an early career cardiologist, that's very helpful because I can think out loud with somebody who has more experience than I do and learn from that. And then I think the third one, just to get back to what we talked about, is don't fast track patients to doing the procedure you want to do. I love doing transcatheter pulmonary valves, but there have been times where I've talked to people and I said, I don't think this is best for you because I'm concerned about this, and also we have great surgical options. Or we haven't yet met the criteria for intervening, so let's wait on it. So I think just kind of maintaining a perspective outside of the cath lab a little bit of this sort of the longitudinal care of patients is
I'm going to cheat and I'm going to go back a little bit instead of ending with that. But in terms of the coronaries, tell me about your evaluation or your steps in evaluation before you say, okay, I'm good to go.
Mm-hmm. Yeah, I think the first thing that we do is we get some sort of advanced imaging, usually CT angio of the coronaries. And then depending on the situation, like I said, we have a lot of bioprosthetic valves, which makes me feel a little bit more comfortable putting a valve in even de facto before we look at the coronaries because it can be protective. But seeing where the coronaries are relative to the conduit, relative to where our sort of anticipated landing zone is important. And sometimes we disqualify patients at that point, not even taking them to the cath lab. And then in the cath lab, I think we have to be meticulous with our balloon dilation and our coronary testing. Sometimes root angiography is adequate, and sometimes it's not. And so we're being prepared to do selective coronary angiography, but with a dilation balloon in place. And putting that balloon up to the pressure and size, the diameter that we're going to put the valve up at. I think not to ruin the surprise, but we'll be talking about a complication tomorrow that happened in our cath lab where it was a high pressure balloon but put up 4 millimeters or more less than what the valve is put up on, and that did result in coronary compression. That was our one in the lab, and I unfortunately was not around to do that personally. But
just for the people who are not going to see that lecture, so what I want to know is, was that coronary in contact with the conduit, or was it more at a distance and difficult to predict?
It was close, but not directly in contact, and it was a very calcified conduit, and they dilated, as I recall, with a 16 millimeter Atlas, so high pressure, but then they implanted on, I think, a 20 or 22 millimeter balloon.
Right. So there's some size
exactly.
there, right? Yeah. That's very interesting. I would share your thoughts completely. So I find it very difficult in anatomy that I'm worried about compression. So for sure coronaries that I know are anomalous, for sure homographs. Less so with bioprosthetic valves where I don't really trouble myself unless the coronary is in a very funny
right
thing
around
that's
the
narrowed.
or something. Yeah. Mm-hmm.
But it's going to be very hard for me to go without a CT angio today. And I mean, we in our lab, we're a selective lab, so we're going to do selectives on everybody with a balloon inflation. I share your concern, and to be very honest, I'm very much of the mindset, and I take a very conservative approach when I'm worried about clipping a coronary, because the consequences of that can be, the risk benefit is not there in that situation, right?
That's exactly right.
Yeah. So I think there's a lot of room to be aggressive, and I think, as you say, when there's good alternatives, you know what I mean, I share a very conservative approach. Yeah. So listen, I think that's great. I look forward to your talks, and I thank you very much for coming.
I appreciate it. Thank you.
Thanks.